We are now going to carry out the practical analysis of this medial side of the knee, and we begin by analyzing the medial collateral ligament. We start by placing the probe on the condyle at the height of the line space and systematically looking for the two bundles of the ligament. First, we see the superficial bundle, which will pass on the surface of the medial meniscus, and then the deep bundle, which will be inserted on the meniscus. Here is the femoromeniscal bundle, and then the meniscotibial bundle. We can clearly see this aspect of a double component in the plane of this medial collateral ligament. From time to time, we even find a small bursitis between the two layers of this ligament. And we see that one has to go high, very high on the femoral insertion of this ligament to completely study it. We scan the entire insertion zone in two planes, the coronal and the axial planes. In this axial plane, it is important to check the connection between the medial collateral ligament and the medial patellar retinaculum. This retinaculum is continuous with the ligamentous structure, and when there is a sprain, there may be a disinsertion of the femoral attachment of this medial patellar retinaculum. Then we will sweep it by passing over the meniscus. We will look more posteriorly at the posterior part of the ligament, and we will analyze the meniscal structure by using a little more gain in the axial plane. We see here that there is the whole middle horn of the meniscus. We come back to the previous part, and then we look at the posterior part, but we will see it in a later chapter with the posterior analysis of the knee. We turn the probe 90 degrees to analyze this meniscal periphery in the coronal plane. We know that for the analysis of the meniscus, it is not necessary to use a very high-frequency probe. A 10 MHz probe is an excellent compromise. We saw the proximal part of the ligament. Now let's see the distal part. We have the meniscotibial bundle that inserts very quickly. The superficial bundle, on the other hand, has a proximal insertion and also a much more distal insertion, which is under the tibial plateau. We see the ligament fibers really go down under the metaphysis. We have on this section, in depth, the geniculate vessels that are crossed by the distal part of the medial collateral ligament, and on the surface there are the tendons of the pes anserine. These tendons of the pes anserine are interesting to study, especially in the event of a distal sprain of the ligament. This is because it is necessary to be certain that the ligament did not come to position itself in surface of the tendons, carrying out what one calls the pseudostener at the knee. Here we looked at the medial collateral ligament in the axial plane and in the coronal plane. Also the meniscus and the distal part of the ligament crossed by the tendons of the pes anserine. These tendons can no longer be individualized at this location because they have fused to form a superficial lamina which, as we can see, is very distal. Do not imagine that pes anserine bursitis is just below the joint line. It's really below the tibial metaphysis, and it's actually very rare. There is a last structure which is very interesting to study in the region of this medial compartment. It is the reflected tendon of the semimembranosus muscle. We spot it on the coronal slice as a notch at the posteromedial tibial plateau. There it is. And when we see this notch, we know that the reflected tendon of the semimembranosus is located there. We turn our probe in the axial plane and look at this reflected tendon, which lines the tibial plateau like a hook up to its anterior part. We see here the fibrillar structure of this reflex tendon that is often affected in athletes and that is very poorly studied in MRI. This is because we are located at the edge of the section, and many pathologies of this reflected tendon are, in fact, poorly visualized on many magnetic resonance examinations. Here we find the posterior ligamentous expansions of the oblique popliteal ligament, which come to extend on the surface of this reflected tendon of the semimembranosus muscle. Now, by bending the knee slightly, we will also study the medial patellar retinaculum. We're going to put a little more gel on because this patient's knee is not swollen. When we do, we'll see the different layers of this retinaculum, which are stretched between the medial pole of the patella and the femoral condyle. We see that in normal patients they are difficult to visualize since certainly there are many structures that are together. But what is important to look at is the regularity of this medial patellar contour. In reality, after dislocation or subluxation of the patella, we will see here small cortico-periosteal detachments. There may even be real tearing that is easy to spot on this section in slight flexion, or possibly even on a simple standard radiograph in the axial projection. Here then, to summarize for the medial plane, the retinaculum in slight flexion, the medial collateral ligament, the meniscus, and do not forget the reflected tendon of the semimembranosus muscle in the posteromedial part.